All right, good morning. This is Senate Health and Welfare. It is Thursday, April 3rd. And we are looking at a couple of bills this morning. We're looking at H 259. And then we're going to move on to the temporary shelter program that's coming to us soon. We're also going to be acting on a bill, so that's good, the healthcare advocate bill. But first things first, H 259, which is an act relating to preventing workplace violence in hospitals. And we have some great testimony this morning. And Betsy Hassan, have I made? I have made, yeah. Great. Okay. So we'll start with Liz Quoto here, and you can come in and we'll introduce ourselves first for everyone in the room. And then you can introduce yourself when you come up to provide testimony. So go ahead, Larry.
Senator Larry Hart, Orange County.
Sam Douglas, Orleans County.
Jenny Lyons, Chittenden Southeast.
Hi, Martina Rockula, Chittenden Central.
And Senator Cummings, as I said, will be in. She represents Washington County right here.
Wonderful.
Yeah.
Thank you. Good morning. Can I share my screen? You all?
Yeah. Great. And did you have this? You sent this in to us as well? Thank you.
We will send it.
You will. That would be great. Okay. So while you're getting started, I'll just share with the committee that Liz and I had a terrific conversation over the summer. I forget whether it was July or August. Her concern was about violence in the healthcare workplace. And I don't think you knew about the bill we had passed last year where we had public safety come in, or the public safety. But then I think you've gone out and done a significant amount of work on your own and bringing people together, and it's terrific. So we're looking forward to your testimony.
Thank you. It was we had a great conversation. You're right. I didn't know the specifics of that. And the end of our conversation, you told me to go write up what we need. And we are here because we did just that.
That's good.
Yeah.
You've written it up. So I'll just give the committee a heads up at about 11:30, more or less. We're going to have Scott Beck in with his proposed amendment for the BAA on essentially, I think he's looking to put the governor's executive order into the BAA. So we'll listen to that. And Katie and I have been through it a little bit, but we'll try to ask questions and see where we are. Wow. What, did you have this coalition before you started this?
No, we didn't. And yeah, I'm going to talk a little bit about that. So I'm Liz Quoto.
Sorry.
That's okay. Jenny, thank you for the introduction. We did start.
So when we're here, you should probably say Senator Lyons.
Senator Lyons, sorry.
Offline, then you can use.
Thank you. Thank you. Thanks for the reminder. This has been quite the process for me, as I spoke to you really just as a nurse leader and a nurse myself, really trying to navigate the system to provide quality of care. And then I've met some really wonderful people and the individuals in the health committee. It becomes personal, so I appreciate that. So our coalition came together actually as a response to our conversation and a couple of other conversations that I felt like I started to scratch the surface on what needed to be done and how we could do it together. to provide quality of care for our community members in all of our hospitals and ultimately nationally for all of our organizations. So the epidemic of workplace violence, I'm, like I said, an ER nurse. I've been doing this for 16 years. I'm certified in trauma care, emergency trauma care for pediatrics, and I'm also a certified emergency nurse. I've worked in New York, Pennsylvania, New Jersey, and Vermont. And so far, Vermont has been one of my favorite places to work, as it is really, we're allowed to have these conversations and we can work together towards what we need at the bedside, as opposed to working in the tri-state area where I come from. It's also a very different pace, which I really appreciate here. And I think we've protected that by working together. So local and national healthcare environment, I'm sure a lot of you have seen the news. Unfortunately, it's been highlighted recent for some serious attacks on healthcare workers. So the police officer that was killed with a nurse, doctor, and other hospital employee in the ICU in Pennsylvania, the Florida nurse who suffered multiple broken bones and potential loss of both eyes. A Kentucky nurse was punched, dragged, and stomped on to Chicago emergency room. Staff members were stabbed, and a patient was accused of assaulting staff in Central Vermont. These are just the ones that have made the news. Unfortunately, this happens daily in all of our organizations, and the process of reporting it has unfortunately been significantly low based on what actually happens in the ER. These include verbal threats. So as outlined in Act 24, verbal threats, physical assault, inappropriate conduct, emotional threats, and sexual threats. I personally have had innumerable amounts of threats. Again, doing this for 16 years, it's hard to walk a fine line of the stories that we deal with every day. The other day we had a nurse that somebody tried to stab her with a chloroprep. Swabs, it's a little plastic piece, but usually just the simple use of a medical device that we use to try to put in the line to help this individual, they turned around and used it to try to assault one of us. I had, when I worked at another facility in the state, I had a gun pulled on me. I would disarm that individual with the tech that happened to be with me. I was very grateful for that. And I was actually unloaded. However, after the fact, to realize that I was escorting out somebody who had unrealistic expectations of what the emergency room could provide. She pulled the gun on me. We called police, and she screamed on the way out the door, "Your family's going to see your body on the streets." So this isn't something that I signed up for. That's not part of my job description. And it's gotten worse over the last 5 to 10 years significantly, to the point where I started to have these conversations, and I wrote a letter to you, Senator Lyons, around what could we do?
I still have that letter. I should bring it in for folks. Yeah.
Oh, I'd be happy to share that as well. So when you dig a little more, again, I just started to scratch the surface, only to find, again, this isn't just how I felt in my organization or the organizations that I've been in. The Bureau of Labor Statistics highlights that healthcare and social service employees have the highest rate of workplace violence, statistically 5 times more likely to be assaulted than any other occupation. 5 times more likely than a police officer who is trained and armed with a gun. Press Ganey states every hour, 3 healthcare employees are assaulted. You might have seen the New York Times piece that was completed at UVM. It was a really great piece that highlighted workplace violence. I only say great because it really did a wonderful job speaking honestly. That was a hard one for me to watch, as I've worked with most of those individuals and experienced it with them, and a lot of their stories I was there for. And that's just highlighting the reality of what is actually happening. It was also shared that unfortunately Vermont leads the nation in days away from work due to workplace violence. So that was a statistic that I don't think our state wants to be known for. And I think that we all want to work together to change that. For the 23rd year in a row, nurses are highlighted as the highest and most honest ethical profession. Yet we are also the highest at risk for workplace violence. So our oath to do no harm is kind of flipped the other way. And we need to put that. So again, I started with a letter. It was starting with honest conversations to make a move towards action rather than potential blame and reaction. In this, I realized through other conversations that there were some other organizations, specialty organizations, like with the Emergency Nurse Association, the American Nurse Association, and the Vermont Nurse Practitioner Association also highlight these as legislative priorities. So the conversations that I was having where it felt like, we were living in our bubble, it turns out there are a lot of other bubbles across the state trying to do the same.
Right, no, the bubbles all work.
Correct. Which it makes you feel better that everyone's trying to do the same thing. So let's try to do this together. I had some wonderful conversations with a very great colleague, provider around how we've all felt in this profession watching good colleagues walk away. So the emergency medicine specialty, our burnout rate is now down to 7 years. So at 7 years, most doctors, nurses, techs, providers that are in emergency medicine are leaving the profession. We are only getting good at 5 years. So we have spent a lot of time getting really good at taking care of people at what sometimes is their worst. And we can't tolerate it anymore. And most of the time this is being cited 1 out of 3 for workplace violence reasons. So I had this conversation, we got frustrated together, and then we said, well, what do we do? Right? So there born a letter, there I met some friends, and here we are. Recently, the ANA put out their new code of ethics book, and as I flipped through it, I found this section that really helped me feel like what we are doing is what we're supposed to be doing. So economic priorities and institution interests focused primarily on profit, efficiency, and budgetary constraints can lead to inadequate human and material resources that interfere with the nurse's ability to provide optimal nursing care. That just seemed like text that was written for everything that we've felt. And in order to maintain nursing practice authority, nurses addressing barriers surrounding rapid and evolving technologies, a lack of experience, exposure, and knowledge, poor representation by those in leadership roles, and unsupported work environments. So again, here we are, because we want to be the people that are at the bedside, that are supporting, making the change that we need to bridge from what your office and your state does to support our ability to care for our patients. Again, I think you're all aware, especially in this committee, the current healthcare crisis landscape, increased emergency department utilization, PCP availability, PCP practice restraints, prior authorization, and I call them hoops, disposition, resource availability, and support services being dissolved due to funding are just a couple of the reasons that we are seeing higher and higher censuses and in emergency departments across the state. So we're a funnel. For all these reasons, people come to the ER. Per EMTALA, we turn no one away, and we won't. All of us are there because we want to care for these people. However, it is becoming more complicated to treat those that come in the door. There are more people. They are tired of waiting. The secondary diagnosis of depression, anxiety, and stress of waiting for these PCP appointments, approvals, has essentially put people into a position where now they're here for help, but also incredibly frustrated, therefore increasing the workplace violence, unfortunately. Recently, we had a patient that the Council on Aging alone advised the individual's landlord to drop him off in the ER because we're considered a safe haven and that we would figure out their insurance and their disposition. Unfortunately, this individual is their own self and they hadn't violated anything in regards to their rent. So they were discharged with what we could provide for their medical needs directly. However, then to turn around, we're scrutinized for the ability of not being able to figure out some sort of loophole. And this takes hours of time. And that is just one patient and very busy emergency rooms that are often compounded with mental health patients that are unfortunately are also stuck in a system that needs support and regulation. And we're running out of beds to just care for patients, period. And we're running out of nurses that are willing to do this anymore. Therefore, workforce shortage is multifactorial. So I'm sure everyone is aware. The need of healthcare is going up, and the workforce willing to do it anymore is going down. Chamber of Commerce projects by 2032 that we're going to be short approximately 16,000 nurses. And by 2030, all of the baby boomer generation will have reached retirement here. It feels like we've all kind of watched this knowing it's coming, and it's coming a lot faster than we all feel like we can be prepared for. It's expected that out of 42 out of 50 states in the US will be experiencing shortage in nursing. Actually, would love to know what the other 8 are.
I think one might be Hawaii, given their healthcare
Okay.
programs.
And unfortunately, more than half of nurses leave their job within the first 2 years. And that, as a leader, I see. So I personally am aware, through personal experience, as well as watching my field, that check-ins are really important at year 2 and year 5. Year 2 is when people are starting to figure out recruitment, retention, what do I need to stay here? And year 5 is when they're really burning out. Where this shortage coming from? We were discussing some local action lately, low retention rates, like I said, secondary to burnout, cost of living versus salary, education gaps. Unfortunately, the support from the education system to find clinical nurses is beyond challenging. I love teaching. We were here for a day on the Hill, and they were like, we would love to have you as a clinical instructor. And unfortunately, the idea of me doing that on top of my job alone, because it's not supported as a position that is sustainable for us, there's no way I could do it as much as I would love to. And I think, definitely side conversations have been happening about how to support them, but unfortunately at this point it has led up to where we are now. And then the aging population. Betsy's going to talk a little bit more about our bill specifically and how it bridges from Act 22, but our proposed solution, again, as our conversation led to, we all came together because we said we want to be a part of the solution. We're all the specialty organizations that represent the nurses in our state and our nation and actually globally. We all have legislative priorities, but we're the people at the bedside as well. And that seems to be sometimes the voice that is missing that can help bridge the gap to ensure that plans laid in order to be successful actually meet where they're meant to be. So replacing a nurse costs approximately $88,000 for an organization. Estimated cost of workplace violence on healthcare is $4 billion a year. Healthcare is kind of upside down. I think we all feel that. But the cost of us to be training and turning over nurses to watch them leave in 2 years is only going to increase the cost of healthcare and decrease the amount of nurses available to do this unless we take some sort of action. It's not only about our safety, this is about protecting the quality of care. For anyone who's ever been in an emergency department or a hospital or primary care, I think the expectation is that everybody wants the care that they deserve. And we're all trained to do that. We're all trained to the highest of our profession, and we expect to give that. But the barriers right now are far beyond what we're able to manage and still provide that care. And I don't want to provide that care anymore. I was thinking about this specifically in regards to when we last met at the house and a couple of situations recently, good and bad. I found my tagline is always "you're safe." A lot of people ask, especially in the emergency department, am I going to be okay? Am I going to die? Sometimes that's going to happen. 16 years I've learned it's not the response. I've learned to use you're safe. So, delivering a baby. Somebody with a 4-month-old recently were calling that, asking, am I going to be okay? Delivering a baby is incredibly complicated and yet incredibly rewarding to bring life into the world. But it's a risky, and I learned to use you're safe. Working with patients in a trauma that after 16 years, I know the outcome. But I don't do any justice in those last moments say the truth. So I use you're safe. I want to tell my colleagues that. And that's why we're here. So I'd like to introduce my colleague Betsy.
Your passion and emotion is so important to us. Thank you. I mean, thank you for sharing, because you've had 16 years of experience and now you're experiencing things that none of us have experienced. I don't think any of us, or some of us, have seen it close to home, but haven't lived through what you've lived, and you bring it right here. So appreciative of that.
I appreciate that. These conversations are really important. And with me, my director from our hospital, and I would like to think that she would categorize me as strong and fierce.
Before we go to Senator Gulick's question, I'd like for each of you in the room to introduce yourselves to us, so we know who's here. That would be terrific. So,
Karen Gallagher. I'm the Executive Director of Perioperative and Emergency Services at Popley Hospital. I'm also a nurse and have been in the field for 33 years.
and you have this wonderful person working with you.
I do. I have a fantastic colleague, and I am very lucky, as is her staff.
Hi, I'm Betsy Hassan. I'm the president of ANA Vermont.
Good morning, Rebecca Silvernagle. I'm with the Department of Disabilities, Aging, and Independent Living. I'm not a nurse, but my grandmother was. And I'm a lawyer, unfortunately. So.
There you go.
I'm Kate McFawn Williams. I'm an RN case manager in the emergency department, and I'm an ANA Vermont secretary.
Thank you.
I'm Devin Green. I'm with Buzz.
Listen, I know that we have Betsy, and we have disability rights, and we have Devin Green, Voz, and Betsy to testify. But at some point, when we get to a wrap up on our testimony, it would be great just to have a conversation on the bill. So we might do that. But before you leave, we have questions.
Yeah. And also just gratitude for your incredible strength and also being vulnerable. Strong women run the world. No offense to my male colleagues, but I so appreciate all of you. And that leads me to my question. We see so many connections between the healthcare system and like the education system, for example, and both of those are highly staffed by women and female identifying people. And I'm wondering if there's data that a lot of this violence is gendered or at all focused on women, or I'm just really, it's fascinating to me in a horrible way that this is happening. And there are a lot of nurses who are women.
That would be a hard one, I think, to look at. I don't know of any data that I've shared through ENA. Correct, it is primarily a female-based profession that has increased significantly over the last couple of years, which has been really lovely to see. I can say that in the emergency department, we specifically, and this is part of the our proposal, is we are trained to de-escalate. So someone that is well trained to de-escalate, gender aside, should be able to quickly read a room and de-escalate a situation. But that's only if we have the opportunity of fair education for de-escalation programs. it is so multifactorial. This work has been really interesting to me because I've really gotten to network about, especially here in regards to other things that are happening that just trickle and touch each other. And then, as I've said, the ER tends to just be the funnel. So all of these issues, where do people go when they need care, whether it's emergently or non-emergently, it's become the ER. So it's been really lovely to have those conversations that link to each other, essentially a spider web. But I can't think of anything.
Yeah, Devin from Buzz, I will say it's hard to tell if it's, I think it probably is. There is a lot towards women. It's hard to tell if it's gendered though, or if it's just that women are in that position more, because when we did this work 2 years ago, there were a lot of male healthcare providers who have been seriously injured. Some couldn't work again. So difficult to say. Yeah. And I'll also just say that there's been a lot of hostility towards the healthcare profession since COVID.
Generally.
Yeah.
And so, yes, and I'm gonna circle here, but the testimony that we heard on the last bill, Act 22, was very clearly we had both men and women who were being attacked. And so one fellow, it was Bennington or Brattle, he was Bennington, who had permanent injury to his arm as a result. So yeah, it's the pressures that build up, as you said, in the emergency room, the wait times and the families, and then the patients themselves coming in with various behavioral issues, and doesn't help you.
Yeah.
Yeah.
And I
the system
understand.
doesn't.
This is, yeah, and once again, we want to help the system. Let us help the system.
Yeah.
Waiting 6 hours to, have your child's arm x-ray because of what else is happening in the ER. I also say all the time, if we're not running into your room, it's a good thing.
Yeah.
And we're happy to see you. We're happy to see you. We're happy to do your x-ray. We're happy to treat you. But the expectation is unrealistic often. And again, that is what is leading people to become frustrated. And it's targeting at us. And unfortunately, not all hospitals in this state have equal standards for safety, security, and workplace violence prevention programs. And for me, that's where it started. I said, it's not fair that I sit in the triage room at UVM with bulletproof glass and security, and I sit in another organization with a door that doesn't even have a window and no security. My risk is exactly the same. And we need to make sure that the barriers that smaller hospitals, larger hospitals that don't even have enough security for the size and the census that they have, is evaluated and regulated equally.
Thank you. So great. Thank you. Great. So let's go to Betsy.
Yeah.
Good morning, everyone.
So I just need to ask one question before you depart this. So are you supportive of H? Or 59? Yes. Yeah. Oh, yes.
Good morning. I'm Becky Hassan. I am the ANA president, and so the American Nurses Association. I also am a nursing director at UVMMC, and part of my role is also co-chairing our workplace violence committee. And my department also houses our de-escalation training and workplace violence prevention coordination as well. So that's where some of this sort of passion and drive comes when Liz and I got to connect and realize that we were going up the same hill. So the reason why we feel policy intervention is necessary is that we really want to ensure that hospitals are accountable to their staff in workplace violence prevention. We want consistency in those implementation of best practices, and those best practices are continually evolving. So what we know is that the last time the OSHA standard was reviewed, or actually their guidelines, was about 10 years ago. And we know that technology has advanced in that time. We know that the way that we do de-escalation and trauma-informed care has changed during that time. And so relying on OSHA is really not considered a best practice. We really want to Liz's point, we want to increase equity throughout the state and where our healthcare workers work in terms of these protections. And we want to also provide direct care staff with decision-making ability. We want them to have input into the interventions that are going to best protect them. They're the ones that know what's happening at the front line, they understand their experiences, and they know how to help mitigate it. And then we want to also ensure that there's consistency in response to workplace violence victims. What we know is that there's the initial trauma of the injury, and then there's a series of events that happen after that that can take almost 2 years if we end up seeking some prosecution. And then an expansion of Act 109. So this is an act relating to safety policies for employees delivering direct social or mental health services. And so we're looking at that as a starting point, and then how else can we protect our workforce?
I think we're having those folks in the, I think we're having those folks in on the report at some point.
So we did a national review and sort of a state review of what is going on in terms of the policy landscape for workplace violence prevention. Right now at the federal level, there is Bill HR 1195, and this is a workplace violence prevention for healthcare and social services workers. This is that federal language that would make the OSHA standard an actual standard within their framework. We also know that with the executive order from President Trump that calls for 10-to-1 deregulation, OSHA is not going to be able to remove 10 other regulations to implement this new one. So really feeling like at the federal level, things are stalled. We also have accrediting bodies. So the Joint Commission, Workplace Violence Prevention Standard. Not all organizations in the state are accredited through the Joint Commission. So they're not required to have that standard in place. And then we also know that there are numerous best practice toolkits for the American Hospital Association, the American Organization of Nurse Leaders, the Emergency Nurses Association, that all update that evidence and those guidelines frequently so that we're always ensuring that the best practices are in place. And then lastly, there is an additional bill that has both the House and Senate side. It's a different SAVE Act. There are a couple of them floating around right now, but this is Safety from Violence for Healthcare Employees. And what this does is provide healthcare workers with the same protections that airline workers have in terms of the response should there be an assault. So then when we look at state level policies, one, we know that Act 24 was passed in 2023. And we know that we're continuing to work on the implementation of that and partnering with DPS on how we best do some collaborative training with law enforcement and with healthcare leaders and staff. We also know that there are a number of states who have already implemented workplace violence prevention programs that are required by state law. The newest one is actually Ohio, and that goes into effect April 9th for them. That was also a bill that was co-authored by a nurse. And that's what we used as our framework when we started to look at which of these programs really work best. And then we also know that there are increased penalties for assault of nurses in 38 states, and we are one of those states as well. So the key elements of our bill are that we'd like to ensure that organizations develop a workplace violence prevention program, and it also has an oversight committee that has direct care staff representation. This is one of the key parts of this bill that we really support. We know that when leaders are making really complex decisions, they aren't able to be at the front line, knowing the experience, knowing what's actually happening, and they might implement something that is costly, but actually doesn't answer the question. We also want to ensure that they have a security plan to address risk assessment, de-escalation, and defensive training plans. These security plans serve as the framework that gets reevaluated at periodic times. So then we're constantly assessing our risk. One important thing is to think about when we know there's been an act of violence, how are we then reassessing that environment to put in best practices or to change our workflows? We also want to ensure that there's training in trauma-informed care to support our employees as victims. And that also follows them throughout their recovery period as well as through the legal process. As I mentioned, there can be times when we have an injury that occurs, and then it's 18 months that finally an advocate is reaching out just to get a witness statement. And so having someone that understands both the legal and the recovery side of that is going to be really important at retaining our workforce. We've also asked for an exemption from the certificate of need process for costs associated with these projects. We know that if an organization needs to put in ballistic glass, it's going to be costly, but it can't wait. And so really looking at, how do we make the right decisions and incentivize organizations to do the right thing? And then we're also seeking a commitment from AHS to work with hospitals to identify incentives and funding sources. We know that AHS has been really supportive of our workforce development work. They have an oversight committee. This would be a really great place for AHS to help us in having some of that monitoring. And while it was excluded from the current version of the legislation, we do want to continue to advocate for a safe harbor from workplace violence prevention budget line items and expenditures from the Green Mountain Care Board budget constraint. Again, it's not that we don't want these items and expenses to be seen. We just need to know that they're a priority and that's the focus of healthcare organizations to keep workers safe. So really, we're here supporting H259 because there's a need to keep people safe at work. There's a need to retain staff and ensure that we have affordable access to care. There's a need to recruit new Vermonters into this healthcare field, and there's a need to not be the next headline. We really don't want to continue to lead the state in any of those statistics that Liz mentioned. And then this really is an opportunity for the legislator to put the solutions in the hands of our healthcare workforce. We're not seeking to impose any sort of rigid, legislation that's top down exactly, that's costly. We really want to help individual organizations work with their leadership and their staff to do their own safety plans and create the best interventions for them to address the violence that they're seeing. And so that's what we're really here to support.
Terrific. Oh, thank you. And everything you've said resonate with us in here. And so the workforce issue in particular, this committee spent a lot of time building the workforce scholarships, lump repayment, all of that. That's been part of our work since the pandemic, during the pandemic, ARPA funds, other funding, and we're AHEC, supporting AHEC in that area. We want you to know that, and that comes from the needs that we see grassroots, you. And then what you've done collectively on this bill is terrific. You've worked with hospitals and others to make it happen, so we're very appreciative of that.
Thank you. Yeah, and I would say that I work with a lot of our programming that has utilized those funds, and now we want to keep them in the workforce, not have them leave.
Yeah, exactly. Questions, committee? All right, well, we'll move right along then.
Thank you.
We've got. She has to go introduce Bill to GovOps, so that's okay.
Sorry.
But you'll be back because we do want to get to, when we finish hearing from folks, we're going to get to H80 and Michael might be a little bit late on that. As you will. Who's next? Devin Green.
And that,
Yeah.
and I know you need to move the agenda along. I know I'll be quick.
Right.
I know.
So the background information that we just heard is
Yes.
outstanding.
Great.
Yeah.
So Devin Green, Vermont Association of Hospitals and Health Systems. I have a presentation posted to your website. You're welcome to look at it. Just paints the broader picture and sort of the economic picture of workplace violence and its impact on our hospitals. And I just want to say, one, I really appreciate this coalition contacting Buzz and coordinating with us. It's been such a pleasure to work with them. I also really appreciate, as we all saw 2 years ago, coming in and telling your story causes re-traumatization. So you know that when people are coming in and talking about these things, they are really looking for action. Buzz supports this bill wholeheartedly. I think it is a great extension of the work that we did 2 years ago. So when we came in here 2 years ago, we were in a place where when I spoke to people about this issue, a lot of the response was, well, isn't that what they signed up for? There was a total lack of understanding of workplace violence. And so I think we've really moved the needle in that area, thanks to your help on this. And then second, we also said, this is not going to be the end. This is not going to be a silver bullet. It's not going to solve the problem. We are going to be back here. And so we are back here and we think this bill really continues this effort forward. A lot of what this bill does actually is put into legislation the recommendations from BPQHC and the report that they did on this issue. And so we wholeheartedly support it. And we particularly support the inclusion of frontline workers into the planning and decision-making process. So one other piece that we support, and just to follow up on with Act 24, is that implementation is ongoing. It has been a process. We worked with Wilda White, who was contracting with EPS, to come up with a standardized policy. That took a while to produce, but it's a really excellent policy. It's being sort of promoted through DPS and public safety and law enforcement. And we appreciate the language in this bill that has law enforcement meeting with hospitals, because I think that will help further the work that you did 2 years ago along. And also just want to recognize that Senator Dick Sears did a lot of work on this issue. He was a great supporter. Yeah. So thank you for your efforts in the past, and thank you for your efforts on this bill as well.
Thank you. Terrific. Who's next? I have Lindsay Owen, Executive Director of Disability Rights, but not here.
She's on the
Oh,
screen.
there you are. Oh, how could I miss you?
Good
Lindsay,
morning.
thank you for being with us.
Thank you so much for the invitation to speak with you all on this bill. So as Senator Lyons just said, I am the Executive Director at Disability Rights Vermont. I've been with the organization for 12 and a half years. I started as an intern and worked advocating, going into the prisons and hospitals throughout the state. I worked as a staff attorney enforcing rights of individuals with disabilities, and have been the Executive Director for approximately 4 years this May. We're the protection and advocacy agency for the state, and we're also the mental health care ombudsman. So we're uniquely situated to inform the committee on this bill because of our federal role to monitor and investigate abuse, neglect, and rights violations. And we receive complaints directly from patients or family members in hospitals regarding allegations of inappropriate seclusion, restraint, and involuntary medication. And we also receive these reports from the Department of Mental Health regarding the same involuntary procedures that really in any other context would be considered crimes, but in the healthcare setting, we permit staff to involuntarily touch, seclude, and chemically subdue other people. I first want to say that in general, DRVT is very supportive of this bill. Everything that's been shared, I agree with 100%. Burnout is real, quality healthcare is necessary, and the safety of hospital staff is incredibly important. So we do really support, this effort to protect our healthcare providers. However, we do think that there's a really important and critical voice that's being left out of this conversation. The work that healthcare providers does is incredibly important and comes with significant risks, and DRVT is not trying to minimize any of that. But all lives should be valued and respected equally, and that may not be a popular truth nationally, but it absolutely should be in Vermont.
We got it.
Sorry.
That's okay. Do we have your testimony on our webpage?
You do not yet, but I will send it right after.
Yes.
Right after. So to continue, we noticed that the bill does ask for safety plan teams to be created with three main groups: the healthcare employees providing the direct care, representatives from the designated agencies, and representatives from law enforcement. But there's no mention of the patient's voice or a person with lived experience in the composition of the safety plan teams or the security risk assessment. This input is crucial, especially in the development of the training requirements, such as, but not restricted to, de-escalation techniques, crisis intervention, trauma-informed care, and strategies. There is also specific regulations that already exist that might go overlooked if this particular voice is not heard. For example, there's regulations in place where you're not supposed to rely on security or law enforcement to carry out emergency involuntary procedures. So the first recommendation that DRB2 would recommend adding would be, I think it's subsection, it would be D, and adding either a self-advocate with lived experience or an advocacy organization with relevant knowledge and experience. Then with regard to the reporting requirements in section B1, DRBT strongly supports that part of this bill insofar as workplace violence includes the violence committed against people in need of hospital care or their loved ones. So through the implementation of these security plans and existing emergency and voluntary procedures, that is technically violence. The trauma that patients experience when they're finding themselves in a situation where they cannot control their own behavior that results in them being physically restrained, mechanically restrained, secluded for lengthy periods of time, or injected with involuntary medication is highly traumatic and violent. So we would just ask that for the reporting requirements that workplace violence includes that population and those behaviors as well. As the Protection and Advocacy Agency, we would suggest that we would be an appropriate entity to receive those reports in addition to those already mentioned. And so although this bill does not specifically identify people facing mental health crises, history tells us that it will have a disproportionate impact on this vulnerable population. For example, last session, the bill that was passed relating to expanding the situations in which a person could be arrested without a warrant for disorderly conduct in the healthcare setting. For women in this group, myself included, I think you'd agree, we checked all the boxes for disorderly conduct during labor. At least I know I did. And we also know no one is sending law enforcement to the maternity ward to arrest laboring mothers. So we just have to be mindful in these current times that the impacts of our decisions will have on the most vulnerable Vermonters in times when services are being cut and protection and oversight is diminishing. So patients in crisis are often unable to control their behavior. These situations are equally frightening to providers and the patient. DRBT supports the requirement for training to enable a situationally appropriate response that protects the provider and the patient and everyone's rights. So I will submit my testimony. So we just had a few recommendations. Again, we are supportive of this bill, and the goal is really to make sure that we're keeping everybody safe, including the patients. And we think that that critical piece is missing from the current draft. Thank you for your time.
Thank you for your testimony, and please do send it in. And please, each of you, we need that on our webpage so we can look through and consolidate our thinking on any improvements we make to the bill. So thank you, Lindsay. And I just say that hearing from the ED nurses and the nurses we've heard from today, I think their primary concern is about the health and safety of their patients. So yeah, I think if you went to one of their services, your clients would be in great hands, but we want to make sure that that happens across the state. Thank you.
Absolutely, I agree. Thank you for your time.
Any questions? We're good. Thank you. Thank you all. This has been really helpful, and I look forward to going through your testimony. It's just great, really great. Thanks for all your work. And Copley is in good hands. So is UVMMC. Got that. All right. Well, we're good. So we're going to move on. I hate moving away from this bill because it's so much fun. The fun part is that you're actually solving a problem, and with great appreciation for your work on this. With a phone call to this is great. A lot of work in between. So Jen, yeah, we'll go right to H80. Great.
Safe travels.
Thank you. Yeah.
More nights.
Oh my gosh. Would she? Oh, her umbrella.
Take orders. Thank you.
Getting right. It's like a plane.
So Senator Gulick will be back. He's up testifying in House Gov Ops. Where is House Gov Ops located
On
now?
the mezzanine.
And
They're on the mezzanine. Yeah, that's,
You're gonna go up and down and.
yeah, in between. Okay, and then Senator Cummings should be in. Do you mind closing the door, maybe? Or like. All right, so we have H80. Do we have a new? Yes, we do.
Jen Carvey from the Office of Legislative Counsel. Yeah, so I have brought you a clean version. Remember, this is the bill relating to the Office of the Healthcare Advocate. And yesterday we looked at a markup version, draft 1.1. Today I have brought you the same thing without the markup. So a clean version as draft 1.2. So here's just to remind you, this is 1.1 from yesterday, and the changes you had made were first in section 2 in the certificate of need process, taking out the allowance for the Office of the Healthcare Advocate or long-term care ombudsman's office to ask questions of employees of the Greenmount Care Board related to the board's review of the application, and renumbered the remaining subdivisions. And then in the healthcare advocate chapter, there was language added where to the subsection where healthcare providers and health insurers must cooperate with the office by providing relevant records and information when they have authorization. This specifically allows the provider or insurer to require the written consent of the individual or their guardian or legal representative before providing the records or information. And then in 9604, changing the requirement to seek input, that state agencies seek input from the Office of the Healthcare Advocate in developing state policy affecting healthcare access and affordability to instead state legislative intent that agencies seek that input when developing or revising significant matters of state policy affecting healthcare access and affordability, and clarifying that's in order to ensure that Vermonters' perspectives are heard and considered through the voice of their independent advocate. So as I said, and that was it. The amendment draft 1.2 is the clean version. Questions? Is that a question?
Yeah, would you mind going back to that actually?
Oh, sure. Good, because I can't seem to get it off.
Okay.
It's already, yes.
Yeah, it was about the duties of care. It was, yeah, right there, may require the written consent. If it's an issue of releasing information, why is that may versus shall?
So they have to get, providers shall cooperate with the office by providing relevant records and information when an individual or the individual's guardian or legal representative has authorized the office to act on the individual's behalf. It was specifically the Agency of Human Services on behalf of Medicaid who wanted to clarify that that could look like written consent and not just oral consent. But I don't know that there was interest in having written consent and all this.
Okay, so verbal consent could be nice.
Right, the authorization could be verbal, but it's also permissible to require written.
Okay, any other questions? We're good. I know, we're gonna vote on this. So clerk, you can get started with that.
Gonna put up, this is 1.2, which is just the clean, for exactly the same thing with the highlighting.
Okay, so it's 1.2 draft.
Strike.
Let's keep an eye on it.
Strike one. Okay.
Yeah,
And
we decided it was easier to,
You said 1.2.
1.2 will be here.
and we'll collect the votes for Senator Cummings and Senator Gulick, because they were also, I think, they're very supportive. I'm not speaking for them.
So you like
Somebody should make a motion.
I'll make a motion.
Okay, so it's a motion to pass
H80.
draft 1.2
Draft 1.2.
as to the full session, right?
Barring the staff, I'll call the roll. Please say yes or no. I call your name. Senator Hart,
Yes.
Senator Cummings,
The whole,
Senator Gould, Senator Lyons.
call yourself first.
I already
You
did.
did? Okay, yeah, I'm yes.
Okay.
So right now we're 3-0, but we'll get the other two because they were here yesterday and wanting to vote on it. We'll just hold it temporarily. Okay, all right, that's great. And I need a reporter, so we hold that until we hear back from them. There may be one of them, they really want to report it, otherwise we have
I'm sure she will.
choices. Yeah. Okay, thank you, Jen. All right. Not too bad. Not too bad.
Oh, complicated and you know.
So now we have this.
No, you're right. Just making sure.
All right. So, just hold on to it. All right.
That's all just skip that.
I think. Let's open here from the reporters of the bill first, and we'll, listen. We don't actually have it yet. We're in.
It's in
Waiting with
process.
bated breath.
It passed the house yesterday.
Excitement,
Yeah.
and, to go through it, and we've got 1, 2, 3, 4 reporters from the House. So
We do have.
first I'm gonna need an explanation of the 4 reporters. And
That's how excited we are about this bill.
Yeah, Representative Wood, you wanna?
We're outnumbered.
Well, we only got 3 of us today.
Well, but here's what I would like to say. I know that we met jointly at the beginning of the session to look at the task force report that came out.
Exactly.
113, and the Representative Gill was very important to that task force report and sort of brought it to us. So we are not unfamiliar with the issue. And believe me, none of us are unfamiliar with the issue. But so we're looking forward.
If we are, then we're kind of living under a rock.
Yeah.
I don't think that's true for any of us anyway. Teresa Wood, Chair of House Human Services. Nice to see you again, Senator Hart.
Very nice to be here.
Nice to meet you. I brought the heavy hitters here with me. Representative Donahue and Representative McGill. Representative McGuire from Rutland City also reported the bill and is supportive of the bill. However, he is out ill.
Oh,
So,
sorry to hear. Okay.
Yeah. So he is not able to join us.
Maybe we'll
today.
get him in another time. Just
That's possible. Totally possible. He was,
what can I just ask?
Yeah.
What is the illness that's going around right now?
I don't know what's going around, but that's not his.
Okay.
He's dealing with other health issues.
Okay.
So,
Thank you.
So thank you for inviting us. And I was very excited. We all were very excited to be invited so quickly after we voted this out on 3rd reading yesterday. And it is a critical bill for the body to pass. It's a bill that replaces the general assistance. It's been kind of, termed the hotel motel program that I don't think a single person in the building likes, and we don't think is the most effective way to deal with homelessness in the state of Vermont. So what you have before you, I'll let Katie's going to go through the bill with you, so I'm not going to do that, but I want to explain the approach that we took. We really, it's not often that you were.
Hold on a second.
Yes,
No.
you can. Somebody can have. I printed one off.
I have a copy here.
Well,
Yeah, like
he will get us copies.
Yeah.
Okay.
It has passed the House. It has gone
Yes,
through 3rd
It's gone
reading.
through 3rd reading.
So that's the one we want.
But
So-
the as passed isn't posted online yet.
Hey, no,
But
that's
they're
the
amended
problem.
at the most recent version
Okay.
of what
All
passed.
right.
Yeah, if you went to our committee page, under the documents, it's our committee report, there were no amendments.
For
Okay.
TPE, go to my fiscal.
I'll send it to her.
Let's-
Draft
Okay.
number 7.1.
Yeah, 91.
Okay,
91 and it says draft 7.1 on the top of it.
okay, that's helpful.
And then, yeah, the as pass version is not posted yet. So,
I know, it's all, there are rules that we follow, and that's one of them.
I know.
Good.
And, but the language is all the same. There were no amendments on the floor to it. The background about this is, last year, we, and the chair just alluded to this, last year we had a bill that, codified the general assistance program in law. Because you might be surprised to find out that even though we spend, millions of dollars in this program, there's nothing in statute about general assistance, virtually nothing. And so last year we set out to rectify that. That bill passed through the House, it passed through this committee, and it stayed on the wall in appropriations. And part of the bill got included in the budget. So a big part of the bill, which was a task force report and process that Representative McGill co-chaired with the housing and homelessness person from the city of Burlington, Sarah Russell. Worked last summer and fall on preparing a report that we had a joint committee meeting on early in the session. And so oftentimes, we're not happy when the Senate doesn't pass a House bill all the way through the process. But I can tell you, I'm actually grateful that that did not happen last year, because what we have before us is a better bill, a better process, and a better solution to the issue of how we support people who are homeless in the state of Vermont. And the reason I say that is because we are not just looking at sort of codifying what exists now. We are looking towards a future that is different than the one that we have now. A future that does not rely on hotels and motels to the extent that we do now. A future that permits and encourages more preventative work. That it permits and encourages decisions that are best made closest to the communities where they happen. And so this takes what's currently known as the Housing Opportunity Program, as well as a general assistance hotel motel program. I always put in quotes because all it really is a voucher that, it's authorization that goes to a hotel. It's not really a program. And it combines the resources from those two areas into what we're calling VCARF. It's got a long name in here, but I'm going to call it VCARF. And it does that because we needed to have an integrated continuum of care around services for people who are homeless, with an intense focus on preventing homelessness. So with the creativity and flexibility that can happen at the local level, that honestly at the state level, it's a one size fits all, so you get a voucher and that's what you get, at the community level, it could be a couple of $100s to keep you staying, with a friend, paying extra utilities and food, or it could be a master lease of an apartment building that a local community action agency or a local shelter provider leases, and the individual apartments are used as transitional support for people who don't have permanent housing yet. It could be a block of hotel rooms that are utilized as essentially a de facto shelter. So it's much more able in this kind of structure to be able to encourage the creative use of the limited resources that the state has and to be more effective. The other thing that we know is that there are about 3,500 individuals who are homeless in the state of Vermont. And we have been serving about half of those people over the course of time. And so there are other people who are out there who need the support. And so without additional resources, we do believe that the flexibility that this allows will enable us to be more responsive to people who are homeless. And as I said, to try to prevent homelessness in the first place. So the sort of major thing that this does is it takes those resources and it moves them into the community action agencies. And it moves them there with the support of the Department for Children and Families, and with those agencies working collaboratively with the local housing coalitions, the continuums of care, which are established pieces of a system that is out there, but not really integrated. It's kind of like everybody doing their own thing a little bit. And so this enables all of that to come together in a more efficient and effective way to benefit Vermonters. It does also call for some one-time funding for the transition process. So I know that Senator Lyons was around when we closed the Brandon Training School, and the General Assembly approved what we called bridge money at the time, because when you need to maintain services at a certain level in the old system, before you're moving to the new system, there's that transition process. Good morning, Senator Cummings. Good morning. And so there was bridge money appropriated by the legislature at that time, back in the 90s. And this same concept exists here in this bill. So you will see $10 million. And there is a fiscal note that Nolan can review with you. And that provides the ability during FY26, the fiscal year that's coming up. It provides the ability for additional staff, additional training, expansion of IT systems, potential, space that's needed to essentially ramp up the infrastructure of the community action agencies, as well as you'll notice, I've been talking about community action agencies a lot, but it also calls out the Vermont Network against domestic and sexual violence. There's reasons why they are included under VHART. However, they are sort of a separate entity that will manage, again, on a statewide basis. They will manage the sexual and domestic violence response. They have to be kept separate because of federal and state rules around confidentiality and protection of people who have experienced violence. So, but they are also part of this. So that transition process is critical. All right, we're making a major change in state government, a major change in the community action agency's operation, and they need this time to be able to transition from what we know now, which is being run by the state, to what the future holds, which will be a community-based, community-run program. And so that transition is critical. And right now, we essentially continue the program as is for the next year, being run by the department, well, in two divisions, the Office of Economic Opportunity, as well as the Division of Economic Services. Because it's, again, right now, it's separated out into two divisions. So that's essentially the elements of the bill. It requires an implementation plan. So there were things that the committee discussed that we felt like the experts in the field should really weigh in and bring back to us. So you will see what I will call a companion bill next year that puts the elements that we feel should be in statute, but this lays out the framework for that to happen. And I especially want to thank the community action agencies, because this is a major undertaking for them, and they recognizing that their mission is around addressing the issues of poverty in their local communities, that this is part of their mission, and they recognize that, and they have been critical, honestly, to the ability to make this shift. And they know it's a big undertaking. They are working already with the Department for Children and Families about some of the issues that need to be tackled. And they're being very proactive about it, as well as DCF is in the Office of Economic Opportunity, really looking at some of the things that would need to be addressed. So just looking to my colleagues here for anything you might want to
I
say.
think that's a terrific overview. I think when you walk through it, what she said just will fall right into place.
I would just add also in our thanks, you called out the Office of Economic Opportunity, but their director was in our committee every day along with CAPS, really helping to make this bill better. And so I really appreciated having that presence and that participation and interaction.
And I guess because I reported the implementation and pieces, so just reference, there were people who said, but you don't have these limits anymore and you don't, it's gonna cost triple, you don't. And that is all there in the implementation plan. DCF needs to come back and say, how will prioritization of people work? How will these things work? They've got to come back with those specifics, so they're not locked in.
And that's that. So we have all next year as the bridge year that you're.
February.
They have to come back on February, they have to come
February,
back
February.
February first.
In case we have to pass
Yes.
Okay.
another bill.
Well, so that's something we can talk about. Is sufficient time for us to make some decisions in this bill?
We expect that there would be, like I said, a companion bill next year.
Yeah.
That would, lay out the things, some of the elements of the, implementation plan that we feel need to be codified. There will be elements of the implementation plan that don't need to be codified, but we do think that there will be some things as you look through the implementation plan that will need to be codified. And so we would expect also to do that next year after they come back to us with their report.
Amazing. Good work. Thank you.
And we
So
are sure we'll improve upon it, I'm
No.
sure.
Of course we will.
I don't bet that, Madam Chair.
It's a team effort.
That's exactly right.
Well, we've been working on this for a long time. so
Yes.
It's nice to see a window of opportunity. And you have worked you've worked collaboratively with the agency that makes a big difference, and also with the CAPS that makes a big.
With the CAPS, with the agency, the
network.
Secretary of Human Services,
Yeah.
the governor's office has been involved. I mean, not in the details,
Sure.
but they're supportive of the concept. The one thing that I want to be clear for the committee is that the only appropriation in this is the $10 million for the transition. The ongoing appropriations would happen next year in next year's budget. So there is not an appropriation for that in this bill because the current programs will continue to run in FY26 and that appropriation's in the big bill.
Right. Okay. That's already in there.
Yeah.
Okay. Is there any comment that Representative McGill or Donahue would like to make further?
Bruce is the pro. Got it all.
Senator Gulick has a question.
Or comment, which is that I'm really sad that I missed your introduction today, and I will go back and look at the video because this is so critical. So thank you.
You're welcome. Thank you.
Good. All right. Well, we're going to have an opportunity to walk through the bill and see exactly what you're talking about.
Awesome.
And knowing that, one of the things that happened during the BAA negotiation with the administration was that the governor's office brought to the conference committee a recommendation that all of the funding go to the municipalities, the local level. And I know that was part of and we're supportive of that, was part of the discussion. I think it was rejected by the conference committee on the Senate side because it was would be a huge endeavor within a short period of time.
Yes.
Now you're bringing us something that perhaps we can do more realistically.
As the other thing that you brought up, municipalities, they are available to apply for grants under this as well. So we would expect that the community action agencies will be making sub grants. So you'll see municipalities mentioned in this bill because we do have municipalities that want to be part of the solution. We have others who, want to be part of the solution, but they don't want to be providing direct services. And so, that's going to be their option. But, so we do have a role for municipalities if they so choose here.
That makes me,
Go ahead.
can I add?
Go ahead.
Yeah, that just
Representative
makes me think you'll see within this over and over just the theme of collaboration, which is really what it's going to take to solve this crisis. So that's collaboration with municipalities, all of the departments in the Agency of Human Services, our COCs, our CAPS. So yeah, so that just builds on that. And I'm excited to have it echoed throughout the bill.
So that reminds me, yes, that reminds me. I think one of the things that we really recognize in this reference is there are all these other departments in the Agency of Human Services that all deal with housing and emergency type housing for their subpopulations, and they don't all. So they are named as they've got to be at the table in developing the planning. You've got corrections with step down housing, transition, you've got mental health, you've got Dale, you've got, every agency.
Yes.
Yeah.
Recovery housing.
all those
Exactly.
referral places.
Yeah.
You did it.
Yes, they all have to be part of this process, and I think that's important. The one thing that I do want to say is that this, the only thing that really solves the homelessness issue is affordable housing. And this is not an affordable housing bill. This is a bill that provides humane assistance to individuals while they are homeless. And we hope that, and we say it here, that it's brief and non-recurring. And you will probably see some of this data when you have witnesses, but the percentage of people who find their way to permanent housing and then find themselves homeless again is actually quite high. And so that's a thing that has not really been delved into. So the department really hasn't been paying close attention to that. And this enables the department to be in the role that it should be, which is looking at the overall system and saying, okay, where's the next place we need to go, and doing the technical assistance and the oversight and accountability. That's, what their role is. And it, just as a side note, it's been interesting. The state auditor's office, I don't know exactly how, but they picked up on this concept of people being placed into permanent housing and then becoming homeless again. And they have been asking around about, what's the data on why, and, what have you done to sort of analyze the situation and to try to approach it? And they didn't get good answers.
Yeah.
It's
hard. Once people leave, they're gone.
Yeah. So, although the fact that we know in coordinated entry that they become homeless again means that they're back in the system. So it's a dilemma, and we know that affordable housing is something that is critical to solving homelessness. And, just as, I feel like I have to say it because there's the global thing of building more housing does not address the problem of homelessness. So, for all those who say all we need to do is build more housing, that is not going to solve the problem of homelessness. These are individuals who, older Vermonters who thought Social Security alone was going to be enough to live on in their old age, and it's not. It's individuals who are disabled, live on SSI, and that's their only source of income. So affordable housing that is being built at a much slower rate is what we need. And that is a long time coming at the rate of, setting aside 30% of new housing. So just felt like I needed to say that because that's what people say.
Staffed housing. Some people just need housing.
Yeah.
Others need a significant amount.
Definitely supportive services. Yeah.
Of help if they're going to stay housed.
Yeah. And that's why we really did focus on making sure that the other departments in AHS, DCF has felt, somewhat at times like they're kind of in this alone, in terms of trying to address the issue when, a lot of the people are people who have substance use disorder, or they might have mental health challenges, or they could be older Vermonters. We know that there are at least 18 people who have already been approved for Choices for Care who are living in hotels. We know that there are people with developmental and intellectual disabilities living in hotels. We know we have a system that supports them. we need to be more active about requiring the level of intervention with all of the AHS departments. We had the commissioner of correction say, well, we have placed people into hotels on their release. I'm like, that's not really a placement. It's an all in, it has to be all in. So thank you very much for your time and attention, and I'll let you get to it with Katie.
No, really appreciate it. Thank you for all your work on this. Well, I'm sure we'll be sending our pigeons out.
Okay. Let us know. We're happy to help in any way.
Thank you all the reporters. We know who you are.
That's right.
That's right. Bye.
And we're missing one. Eric McGuire is out sick today, so he's part of the group. I forgot to say the vote was 8-1. Eric was out sick that day, so it would have been 9-2.
Okay. And the floor was
voice vote.
I mean, I'm working.
That bill.
Brenda Steady and Representative Steady and Representative Nielsen. Steady of Milton and Nielsen of Brandon.
So 8-1.
Yes. Representative McGuire, as he said, was out sick. He reported on the floor that he supported the bill.
And the voice vote was not 100% party.
Yeah, got it.
Yeah, no, there were. This issue is not partisan, really. You know, there's everybody cares about people.
Everybody's should be on their own.
Yeah. Alrighty, thank you very much. Appreciate it.
Thank you,
Alrighty.
Representative
Good luck.
Wood.
Alrighty.
So,
Good day.
Katie, would you be upset if we took a 2-minute break?
Not at all.
So, yeah, we've been through a lot this morning. So let's come back at 8:30.